This year at ESMO, unfortunately, we have not seen a practice-changing data regarding early breast cancer, but there was a number of studies, very interesting studies, which are hypothesis-generating and which prove some concepts and demonstrate activity of some new strategies and new agents and point into future directions of research. And probably the two most interesting studies were the two neoadjuvant studies with new targeted agents. One was a very important study comparing chemotherapy versus endocrine-based therapy combined with CDK4/6 inhibitor palbociclib in neoadjuvant treatment. This study failed its primary endpoint, but my personal feeling is that the primary endpoint was not chosen well, because actually the study demonstrated very similar, if not equal, efficacy of chemotherapy and endocrine-based therapy, and this was a modern third-generation chemotherapy. And the only difference was really in the toxicity, which was of course much higher with chemotherapy. So if this can be proven with longer term outcomes, this would be great news that we can spare chemotherapy from these patients. So this is first important information. The second comes from LORELEI study, which is the first study which demonstrates activity of alpha-selective PI3K inhibitor. This was tacrolimus. And this study demonstrated improvement in response rate in neoadjuvant treatment in patients given combination of aromatase inhibitor plus the PI3K inhibitor versus aromatase inhibitor alone. And what is even more interesting, that the larger benefit was seen in this pre-selected population of PIK3CA mutant patients, which from the preclinical data are expected to be more sensitive, and which unfortunately is not seen in all studies with new agents. So we have new promising agent, and we are looking forward into further data, but the first data appearing from neoadjuvant study is really a very positive signal. And also this is a first selective PI3K inhibitor, and the data with non-selective inhibitors demonstrate the biological activity, but unfortunately there are problems with toxicity, which really limited further development of these agents. So now we are looking for more specific agents, and one of them is the tacrolimus, and I'm sure this drug has a future in front of itself, and I'm looking forward to it. Besides, there was also confirmatory data on the long-term follow-up of the ExteNET study, which is the late adjuvant anti-HER2 therapy with neratinib. These similar results were presented earlier, and the drug neratinib is now approved in the US for this indication, but it's very reassuring to see that the same results are really seen after longer follow-up, although I do have mixed feelings whether this drug is really a big progress, because it's a quite relatively toxic compound, and in this setting, given after termination of adjuvant trastuzumab, I don't think the compliance of patients would be very good, because patients do not want to go back to treatment after that long, especially if the treatment is going to be toxic.